Welcome to today's breakout broadcast entitled Current Data and Future Direction in Left Atrial Appendage Closure. My name is Dr. Arzamendi. I'm Chief Interventional Cardiology at Hospital Sant Pau, Barcelona. And I'm delighted to be joined today by Professor Ole de Backer, one of the most experienced LAAC closure operators from Rigshospitalet Copenhagen. Hello, Ole.
Hello, David.
So before we start, I would like to go quickly through the agenda. As you know, we'll be working mainly with three topics. And I will go through the streamlining of the left atrial appendage closure procedure. Ole will work mainly with the preoperative planning of the appendage closure. And I will do a quick review about the current data and the future needs of left atrial appendage closure with the Watchman Flex. This session today also has some learning objectives. One of them is working through the different imaging modalities that we use for left appendage closure. At the same time, we will talk a little bit about the new implantation techniques of the Watchman Flex and how can we optimize our results. And also we will review some clinical data that will be really useful to use them after with our referrals to combine them even more to refer the patients to us for left appendage closure. So, and I would like to remember also that today's session is an interactive session. So if you have any question, please submit them and we will try to answer and to address them as soon as we can during the discussions. I won't waste more time and I will go directly through my first presentation that it's about the streamlining of the left atrial appendage closure procedure. So as we know, current training in structural intervention procedures is to be increasingly minimalist. As you know, we try to avoid the number of vascular access. We try to avoid anesthesia because it makes the recovery longer. We try to shorten the hospital stay. And for doing all that, obviously, we need an adequate screening of these procedures. We also know that the ICE and the micro-TE have been really perfectly used for really simple procedures as PFO and ASD closure. And with this rationale, we have tried to move this sort of imaging techniques to support our procedures for a left appendage closure. And which is a rationale for being minimally invasive. So the first and probably the main reason is that we look and we always have to look for our patient's comfort, as you know, and avoiding anesthesia and makes the recovery of the patients much more quicker. In the other hand, we also know that there has been a really boom on structural heart intervention procedures. There has been an increase on TAVR, mitral clip, etc. So we are having a lack of anesthesia. And there are several studies that have been showing that doing these structural procedures without anesthesia can be safe and we can achieve the same results as doing them with general anesthesia. And in the other hand, there is another variable that we have to take into account that the COVID-19 has made us to be more creative. And in some points, we have been really busy in our hospitals with a lack of beds. And so we have to be able to manage the situation, trying to minimize the stay of our patients in the hospital. So to do this sort of procedure and make them much more easier, and I think the key point is the screening. I think Ole will go through that, but probably we all do agree that if you're gonna go with some imaging support that is not the regular TOE, you have to have a really good evaluation of the patient. And probably the CT scan it's becoming the gold standard for that. There are several different programs that we can use from Tremensio to FIOPS. In this case, I'm showing a case analyzed by Vida, and you can analyze perfectly which is going to be the landing of your device. You can do different measurements. You can see the central line. So before you go for the procedure itself, you already know which is going to be the device that you're going to use. After that, if you need to choose one of the imaging techniques, probably the first and easier step is using the micro TOE. The main reason is because it's really similar to the regular TOE. The only difference is that the probe is much more smaller, and this allows to use it directly with no need of general anesthesia. and it allows also fast change of the patients. And obviously, once you have the probe, there is no more waste of money. And the only limitation of the technique is that you have to have your echo operators all the time with you. And in those cases that the reason for appendage closure is bleeding to esophagus bleed, etc. So this is something that you would like to avoid. So this is not something that you solve with the micro TE. Instead, with the eyes, you have the main advantage that you have the same probably advantages of the micro TE. You can also use it on those cases where you have esophagus varices. But the main advantage here is that you don't need another operator. You can do it all alone. But it's true that probably you need a learning curve, and sometimes you feel that you are doing multitask because you are deploying the device at the same time you are trying to have a good view of the appendage, and sometimes this can be somehow cumbersome. This is how we do the eyes cases. As you can see perfectly, you can guide your transeptal. You can have a really nice view seeing how we are doing the puncture inferiorly. And once we do the puncture, what we do is we put the extra stiff wire in the pulmonary vein, and we dilate the septum with the implant sheath. You can see here how we are advancing the sheath. And after that, you pull back. And once you pull back, you can see that the echo probe goes directly through the hole that you have created. It's a pretty simple maneuver. So you do the dilatation, you pull back, you feel the resistance when you pull back, so you know where is the hole. And after that, you just follow the wire with your echo, with your eyes probe. You can get almost similar images that you got with a TOE probe. So you can see here we are getting, and if you go close to the mitral valve, as you can see here below the device, you can get like the 135 imaging of the TOE. And instead, if you go up and you do the retroflex just pointing to the device, you can get something really similar to what you get with the TOE in the 45-degree view. It's true that you can probably just do the same evaluation as you do with a TOE, so you can go from 0 to 180, but you can try to do a slight movements and rotation to get almost most of the views that you get with a TOE. The main advantage of the micro TOE is that you can get exactly the same images that you get with a TOE, but probably the quality, as you can see, is not as good as you go with a TOE, but it's good enough probably to guide these procedures. As I say, if you got a prior good screening. Once you analyze, you can even remeasure it. And after that, when you do the implant, you can analyze perfectly if the device is well settled. You can go from 0 to 180. You can check with the color if you have any leak. And probably the quality of the imaging it's a little bit better than what we got currently with the eyes probe. The way we work is once we do the procedure, we try to discharge the patients the same day. For that, we consider most of the times we do a pre-closure of the vein, because when you do the 8 suture, sometimes you have some more bleeding after the procedure, so this can make more difficult the discharge of the patient. So we do the pre-closure with a ProGlide. After that, we do a control at 6 hours. We check the vascular access if it does look good. And we do a pre-discharge transthoracic echo, but it's just a single view to check. You go to the subcostal view, you can check that the device is in place. There is no pericardial effusion, so we are sure that it's safe to discharge the patient. So the patient goes home 6 hours later, and after that we organize a follow-up CT 6 months later. And with that, the truth is that the patients have a really good comfort. They can sleep at their home, and they really feel better with that. There are several questions that might arise. It's that the first is if this way of working is safe, if we have the same success rate that we got with a TOE, if this is more time consuming, what about perivalvular leaks? Is this cost effective? Does it really increase the comfort? And the thing is that there is a good news is that there is already a study that has been done, that it's the LAAC, that it's a study that is being done with Watchman eyes and guided with eyes, and 100 patients have been included. And the truth is that we haven't still published the results, but probably this will show or this will answer the questions that we have done before. But I can assure you that probably will show that this is something safe, and this is something that can do routinely with all the patients. Thank you.
Thank you, David, for this interesting lecture, really interesting, on the simplification of this procedure. I see that in the meanwhile, there's also an interesting question from the audience, and that's exactly this one. Which of the modifications you implemented during the COVID-19 are you keeping or planning to keep for your day-to-day practice after COVID? So did you change your practice due to COVID, and are there some of these elements of simplification you're going to keep afterwards?
Sure, and what we did is normally those patients got admitted directly in the hospital in the ward. We used to do the procedure, and after that they went back to the ward, and we discharged them 24 hours later. Now they come directly to the recovery room. So we have like a small recovery room here. They come directly here, so they don't need to have an admission. We do the procedure, and after that we keep them there for 6 hours. We check that everything looks good, and after that they are discharged. So there is kind of we have become kind of sort of independent from the hospital in this sense. So this, when there is a crisis of COVID, it really doesn't affect you because you can use your recovery and it's not a real ward. So this is one of the main advantages probably.
And this approach, or in general, that early discharge kind of protocol, do you use this now in all your patients or in a certain percentage of selection of your patients, or?
So the thing is that we use in most of our patients, but it's up to the screening. I think on those cases, for example, that we saw that there is a thrombus on the appendage during the screen, those cases we normally do them with TIO guide, and so we can recheck clearly we're not interfering with the thrombus, and we do it also with carotid protection with and to be sure there is no problem with that. But the rest of them, if the anatomy is not really complex, I could say that more probably over 90% of the cases we are doing ICE guided with this protocol.
No. And then if we talk about simplification, or then it's and keeping possible complications as low as possible, I think you managed also access, even echo guided access is probably even important there. I think personally, doing these cases, the transeptal puncture, that's maybe a part of the procedure that could be simplified still. Do you have some idea about this? Do you know about these versa cross wires, etc.? Are you fond of the idea that you can simplify this step, or do you think I don't really need this?
I think all these things can make the procedure safer, no? Because you always can have the bad chance to do the puncturing not in the proper site, and more than that is sometimes that you slide at the moment that you are pushing your needle. So if you can have like more precise puncture, I'm pretty sure that this might help to reduce the pericardial effusion. Indeed, this is something that we'll talk later. I mean, I'm surprised during the revision of the evidence that the high rate of pericardial effusion that we can still find in some of our studies. Yeah.
All right, good. I think we want to stay very sharp on time. So I think if that's okay with you, we move on to the next lecture, because it's also related to simplification of your procedure. If you want to really simplify that procedure, the moment you're in that cath lab, I think your pre-procedural planning is really key to be able to simplify your procedure. So my lecture is going to be about this topic. So new insights in LAA closure preoperative planning. Before I start this lecture, I want to remind the audience also to submit questions if they have had any, okay? So, new insights in LAA closure, pre-procedural planning. Well, let me say, still today, official instructions for use from the companies are based on two-dimensional TEE, which is a little bit surprising. So everybody knows these typical measurements of ostium, or in some cases also landing zone at 0, 45, 90, 135 degrees, and this is all based on two-dimensional TEE. However, I believe there are quite some limitations of LAA imaging with especially then two-dimensional TEE. First of all, there's an impossibility to get a full 3D overview of the LAA. Sometimes there is missed a lobe, especially if you have the CT up front and then you see your echo afterwards, you don't always immediately discover all these lobes. There's a lot of variability of the measurements, both inter-operator but also inter-patient. There's no visual accordance with fluoroscopy images, which you have on CT. There's of course the discomfort of the patient, and typically you do these procedures, if you do them with TEE, in general anesthesia or at least in conscious sedation. So one of these limitations, the most important limitations of LAA imaging and sizing with TEE is the following, that the maximum diameter that you measure at your ostium, for example, is not necessarily your true, real, actual maximum ostium diameter. On the other hand, on CT, if you do a 3D reconstruction, what you really measure is the real, what you measure as a maximum or a perimeter-derived mean diameter is also the true actual maximum or perimeter-derived mean diameter of that patient's LAA. So it's more accurate. And that you see also translated in the fact that if you make a TEE measurement, the rule is typically to add 5 to 6 millimeters, for example. That's just simply because your maximum diameter that you measured on your TEE is simply not the true maximum diameter. You have to upsize a bit, and then you also see the limits of agreement. The variability is quite large. So sometimes you just miss size, or you take it wrong device size selection. On the other hand, with CT, you upsize less. You typically upsize only 2 to 3 millimeters, and the variability of these measurements are much smaller, which makes that the error you make or the cases in which you have to change device size selection are kept to an absolute minimum. So your measurements are more precise. So for me, preoperative planning with cardiac CT, it's possible to get a full 3D overview. You never miss any lobes. There is a limited variability of the measurements. Even if me or one of my fellows measures it, we typically measure exactly the same. There's a visual accordance with fluoroscopic views. So if you can upfront predict how that appendage is going to look from an areocaudal or areocranial view, there's limited discomfort for the patient, and it gives me the possibility to perform LA closure in local anesthesia with ICE guidance. For me, you can also do it still with TEE or micro TEE guidance, but then it's simply purely to guide the procedure, to have a safe procedure, not to do any sizing, etc. during the procedure. The only drawback is, of course, use of contrast. I would say the contrast you give during the CT, you save during the procedure because you have to do less contrast injections. So that's my take on use of CT. So better 3D LA assessment, also more accurate measurements of LA dimensions. You can calculate your most optimal C-arm implantation angle. You even can get information out of your CT for where your most ideal transeptal puncture will be, as you've seen during the live case also. And then CT also gives you the potential to do preoperative advanced planning with computational modeling, or even during the procedure, you can have CT fluoroscopy fusion imaging, which may be more used in the future. So there's different software packages. I won't go through all of them. This is, as I showed you during the live case too, you can see nicely the 3D reconstruction. You can have your minimum, maximum perimeter-derived mean diameter of your specific ostium or wherever you want to measure. Even there is advanced software, as you see here, from Materialize, but I know that David is also collaborating with other people on that, where you can have throughout the whole central axis of the LA, the dimensions of the LA with the minimum perimeter-derived mean and the maximum diameter. So this is all still in study context, but this is probably where the future is going to. And why is this important? Well, because nobody would do ever TAVI but with only just one single measurement of the annulus, for example. You also want to know what the structure is in entirety. And these are, for example, 3 examples where you have both at the ostium and if you would measure a landing zone, where these are exactly the same in these 3 cases, but you see also the distality, how this appendage is more distally, if it's wide open tapering again, or if it's getting very tapered, it will probably influence your device size choice. For the middle one, I would go, for example, for a Watchman Flex 27, whereas in the left scenario, I would go maybe for a 24, and in the right scenario, I have maybe the depth and the width for a 31. So this measurement of only an ostium or an ostium and a landing zone, that's probably not enough. We want to have a knowledge of this entire appendage. Also, this is an interesting one. I think that information you get out of your cardiac CT, the optimal implantation view or optimal implantation angulation. What is exactly this optimal implantation view? Well, what do you want to see there? You want to have the ostium, or if you also measure landing zone, an ostium aligned. So you want this structure aligned, that there's no parallax or there's no tilt in that plane, that you align it just like you have the S-curve for when doing TAVI, you also can make an S-curve from this LA ostium, for example. You also want to have in this implantation view minimal foreshortening of your LAA, and the more you go REO or the more you go LAO, again, the more foreshortening you will have. So typically in an REO 25, and then you can compensate a little bit cranial or caudal, and then take your parallax out of your ostium, and that's typically the best optimal view. Also, you want a minimal overlap between the left atrial appendage and the left atrium. So in this particular case, for example, you come to a view of REO 30 cranial 5. Also, transeptal puncture, here you see in most of the cases, it's I would say in 100% of cases, it's always the best an inferior puncture, but it's not true that it's always the best for a posterior puncture. You saw the live case we did, that was a very vertical takeoff on the left atrium of that appendage. So there a posterior puncture could have brought us in problem. We wanted to avoid even the posterior puncture. We wanted to go for more neutral, central, but very inferior puncture. So all this information you can get out of a CT. And especially if you have to deal with a reverse chicken wing, you have to avoid especially posterior transeptal punctures. You want even to go more very inferior, but even a little bit central to central anterior even, so you can fall very nicely with your delivery sheet into the central axis of your appendage. So all this information you can get upfront before starting the procedure, and that of course is a recipe for success afterwards during your case. If you want to bring it to a higher level even, and you want to do computational modeling, that's probably even the future, I would think, that where you can have device-host interaction predicted upfront. And here, for example, in this case, there's a Watchman flex simulated. You typically get for you doubt between two device sizes. In this case, apparently a 24 or a 27. And then you can simulate, you can get these simulations or these models in a proximal or a more distal position. So here you see the 24 flex, Watchman flex in a proximal position is not acceptable. First of all, there's a tiny bit too much shoulder, I would say. And there is, I go back, a tiny bit shoulder, and there's too little compression. Whereas a 24 in a distal position gives a 15% compression. It looks good, the ostium is closed, and there's no peri-device leak. Yeah. Then a 27 is also a possibility, I think, in a distal position, although you get a little bit more shoulder. The 27 in a proximal position is far too proximal and too much shoulder. So here, I think both are you can defend, but we went for the 24 in a distal position with the perfect results. So based on that CT, you can make your pre-procedural plan. And as we do, then very often we do the percutaneous LAA closure and local anesthesia with ICE guidance. You know upfront which curve of delivery sheet you're going to use, and it's going to be the best for this case, and which device size. So we don't have discussion about all this during the procedure. We just simply execute our plan. So finally, the last minute of this presentation, I want to focus maybe a bit more on what in the future. Well, there is a possibility also nowadays to have CT fluoroscopy fusion imaging. Here you see that some of these CT markers, not the entire structure, but just the ostium, for example, the central axis, the fossa, they can be fused on your fluoroscopy. Of course, it's not a moving structure, but it gives you typically a very good understanding of where to be. It can simplify your manipulations of your catheters and of your devices. And then what it could be then even the further next step is where you have these simulations, these computational models, you can even fuse these on your fluoroscopy. We did a couple of cases of this in Copenhagen, also somewhere else they already did, and it looks very promising. So to finalize, I think new insights in LAA closure preoperative planning. You see CT, we use it in order to prepare this procedure in a holistic way. In a way, we get a lot of information out of this. And also, I know that Boston Scientific is working on this, and they will come soon with this Watchman True Plan, where you can, based on CT, have all these pre-procedural plannings, as I demonstrated you with some semi-automated sizes, estimates, compression estimates, also even about imaging, etc. So this is something for the future that's coming, and I think it's coming there end of this year or next year. We'll be ready. So thank you for your attention. So David, I don't know if you have some specific questions. I can see there are some questions from the audience, but otherwise, maybe you can start first.
Yeah, I think it was a wonderful talk, and I do understand that there are still questions. So let's the audience to be interactive with us. So you can read perfectly the question, but one of the audience is asking which are the differences you notice in the procedural aspects since you are using the CT for the planning.
I think it's very important. If you would switch to CT sizing, be careful. Don't follow the official sizing charts from the companies, because these are based on TEE. So you always do much more oversizing based on TEE. So be careful. If you use CT, you have to learn that what you measure on CT is the more true real dimensions of these patients. And typically you upsize less compared to TEE. So that's something you have to learn. Don't use these official TEE-based sizing charts.
I think this is a really good message. I think we personally have some little rules, but one of them is that we don't go over the larger diameter that we got with the CT. So
exactly.
In the case you have a 24 by 18, so the device will go 24. It won't go over that.
I fully agree. For a Watchman Flex, for a Watchman Flex, if you would measure at the ostium, for example, a max diameter of 24 and a minimum of 18 and a perimeter drive mean of 21, probably the 24 will be the correct size. So it's almost matching your maximum diameter. And indeed, it's because compared to the perimeter derived mean, you still have that compression of roughly 15-20%, but then typically you don't go a lot over your maximum diameter you measure at your LAAC ostium on your CT. So that's a very good, I fully agree on that, David. Yeah.
And the other thing is that with the CT, you can analyze better what's at the depth of the appendage. I think sometimes with the TOE, it's difficult to understand what's going on with the lobes. If there is one or two, they can't check it perfectly. And with the CT, you can see how far are you going to be able to go with your sheath. So if you will have more room to go a bit deeper, because you show a planning of going deeper or no, but sometimes it's not so easy to go deeper, because as you say in the chicken wing, so that is a chicken wing, you can go with counterclockwise, so you can plan it in a better way also. So I think CT gets a more similar anatomy that you got with your angios during the procedure.
Yeah. I fully agree. And then there's a question I see, if you have limitations in CT capacity, which patients will you prioritize? Yeah, that's a hard one, of course, because you don't know up front what you see. I mean, I would say we do them for all. We do pre-procedural CT on all patients, and it's rather easy for us to obtain. And also, if people would doubt what kind of protocol do you need, you can do specific. There are protocols for sure available specifically for LAA imaging with CT. But if you would ask just a TAVI CT, a pre-procedural TAVI CT in your hospital, which everybody knows, that then you also get good images for sizing your LAA. So it's not an advanced CT. You can use the same. Only if you want to screen for thrombus also on your CT, you have to do some late acquisitions as well. Yes. Okay. Good. So I think in the sake of time, we're perfectly on time. We would like to keep it like that. So now I'd like to hand over the word again to David for his final talk on current clinical data and future needs. And before he does that, again, I want to remind the audience to submit questions. It's nice if we get the questions and we can tackle and try to answer these. So David, it's yours.
Thank you, Olen. Thank you for the introduction. So the first thing that I want to say is that we have to give the merit to Boston Scientific for generating the evidence of the appendage closure, because as you can see, this is what we got from PubMed. And there is an increase in literature with Watchman studies through the years. So this is something that I think it's really important, because this is what will change the indications of the procedure itself. In the other hand, we also have to be fair to say when the companies work hard. And I think in this case, there is a really, really significant change from Watchman 2.5 to Watchman Flex. I remember when I got to see this first picture several years ago, and to me it didn't look a really different device. Probably I'm not an engineer and it's my lack of knowledge. But when I started using the device, I realized that it was a completely different device. And I also realized that probably the name fit perfectly with the device. It was a really flexible device that you have always the feeling that you are putting like a sort of a cotton into the appendage, and it's really, really adaptable to different sorts and anatomies. So the truth is that the initial experience with Watchman Flex has been really positive. As you know, one of the first studies was the Pinnacle Flex, where more than 400 patients were included. As you know, the results were really positive. It really showed to be really safe, with really low rate of complications. And in the 2-year follow-up, you can see that the rates of a stroke, hemorrhagic and embolic stroke, was pretty low, and really, really acceptable data, really compatible to the main endpoints that were published before with the Watchman. Probably the main advantage, one of the positive things, and maybe it was kind of surprising, but it was a really positive message, is that the DRT rate was really low, 1.8 to 2 years, and this patient had a really strict follow-up. So this is really something that makes the device really interesting. Sometimes we can think that this was a really selected study, because normally when new devices are starting, and we choose always the centers with more experience. But the good thing is that later soon, the SURPASS study showed the real data of the Watchman Flex used through all sorts of different hospitals. More than 16,000 patients were included in this registry. And the positive news are that the results are really comparable what was published with the Pinnacle Flex. You can see really safety, or even a stroke rate, really low rates. And this makes that to be really positive with the new changes with the Watchman Flex. Moreover, when Watchman Flex was compared to the old version in a propensity match study, we could see that the device showed to be really a bit better than the old Watchman 2.5, mainly on DRT and on the ceiling. So there are two features that have improved. Probably we can reduce the peri-device leaks, and also we are seeing lower rates of DRT. So two really important things that are happening with the new Watchman Flex. Indeed, as you know, the Watchman device has been compared head-to-head in the AMULET ID trial. More than 1,800 patients were included in this trial, comparing the AMULET device with the old Watchman device. And the good thing is that in the main endpoints and in the primary combined endpoint, both devices behaved in a really similar way. The main differences, as you will see, they are related to the secondary endpoints. Watchman Flex shows to be a bit more safe in terms that the rate of pericardial effusion and the vascular complications showed to be lower with Watchman Flex. But it's true that, on the other hand, the rate of peri-device leaks seems to be a bit lower with the AMULET device. Indeed, as you know, this year has been published the Swiss Apero, comparing the AMULET mostly with the Watchman Flex device. And as I said, the results are pretty similar in terms that it seems that the periprocedural complication rate is a bit lower with the Watchman Flex device, mainly due to lower pericardial effusion and lower vascular complication. And instead, when we check the perivalvular leaks with the TOE, they look a bit lower in the AMULET group. But to me, instead of comparing device to device, I think to me the most interesting studies are those that are comparing the technique with the NOACs, mainly because the main indication nowadays, at least in Europe, is for appendage closure are patients with contraindication to oral anticoagulation. So trying to increase the indication of the therapy, I think it's the most important thing for us. And for that, to me, the most interesting study published this year is the PRACT-17 that has published the 4-year follow-up of these patients. And as you can see in the Kaplan-Meier, the curves are diverging over time, mainly due to the reduction of bleeding complications with the device compared to those patients treated with NOAC. The positive things of that is that there are 2 other studies going on comparing the left appendage closure against the NOACs, and Watchman Flex is being compared in the Champion trial that is nowadays it's still in the inclusion in the gruesome way, and hopefully we'll have results soon. As you know, there is another study, it's the Catalyst trial that is comparing amylase to LAAC, and I hope that with these two on PRAC, we'll be able to switch the indication of left appendage closure. So in summary, I think Watchman Flex has shown to be a really safe and effective device for appendage closure. I think the evolution of the device has supposed an increase in the sealing profile and a reduction on DRT, two things that were a bit criticized to the old Watchman 2.5 device. So I think the engineering switch has really come with a better result on the procedure itself. And I hope that future studies comparing left atrial appendage closure against NOACs might change the broad prospect of patients to treat. So that's it. Thank you.
Thank you, David. Great overview again. And well, we have a couple of minutes to discuss this. First, let me say, I mean, these clinical trials, as you are presenting here at the end, also the ones who are running and still including patients, we really need these trials, yes, because we want to push this field further. And we can only push this field further if we include patients in these trials. So it's an important thing to include these patients. You started also by showing the device. And what was for you, if you have to highlight 2 points of the new Watchman Flex compared to the previous generation, the 2.5, what were for you the 2 most striking on the best improvements?
And to me, it's mostly the flexibility of the device, that you have the feeling that independently what you do, the device will fit into the appendage.
The conformability,
so I had the feeling,
yes?
That's right. Yeah. That in the past I had my feeling with the 2.5 was that you had to work harder to put the device in the spot that you wanted exactly to get a proper result. And with the Flex, you had more the feeling that if the sheath is just really axial to the appendage, when you open it, it really adapts and it really conforms to the appendage independently of the shape. And I think the main difference that I found with the Flex has been in those chicken wings, that and with the 2.5, sometimes it was difficult to take a decision. Sometimes even we need to switch one device from another. And with the Flex, I have the feeling that you can do the same thing that you do with other sort of devices. And so my feeling is that despite what the study said, I think the success rate that we are getting is higher because in terms that we are approaching more patients that probably in the past we will have used another device probably for that. And now I think I don't have this feeling. I think that you can close exactly the same appendages that you are closing with other devices.
Yeah, I can confirm that. I mean, the device is very conformable. That's very nice. And that's why maybe there's also more error margin on the sizing. So even if your sizing is not up to the perfection, there's a quite range where you can go from 10 to 30% of compression. So it's rather forgiving. It's more forgiving than in the past or with a more stiff closure device. Do you think that if you had experience with the older device, that really plays a role? It's important to implant the new device, or regardless of that, it's another implantation technique, you think? I
think it's completely different. At least me. I mean, I think as we said here, you have the fact that that it's a closed device. You have the feeling that it's really safe to open it deep in the appendage. Even for the recapture, it looks easier. And I think this comes also with a safety issue. I mean, if you check the pericardial effusion rate, it's pretty low. And it's difficult to explain with the same operators and relate this all to the transeptal puncture. So probably the device itself has something to do, and the hooks, et cetera, et cetera. So that shows that the device is really, really a safe device, and that was my feeling. And the way we implant it it's completely different. We really feel safe opening it deep in the appendage, and after that going with a slow deployment. And with that, we are able to get almost perfect result just with one shot.
I agree. I mean, especially that's what I personally did not like on the previous devices, that recapturing was not easy or not without a risk. You had these barbs which were open and were potentially traumatizing. Now, because it's a closed distal end, as you mentioned, it's so easy to recapture, reposition. It's very soft, very atraumatic. And that's why also I think we see these very low complication rates in all these registries and trials. And also, if you mentioned something about peri-device leaks, I think that's referring also still to a study which was mainly using the Watchman 2.5. I think now with the Watchman Flex, because as you were mentioning too, the device is much more conformable. I think the rates of complete closure will be spectacularly higher using the Flex, I think. But as a last point, we have still 2 minutes before getting to the closing remarks. I think, can you, if we talk about peri-device leaks or device-related thrombosis, what is your regime of post-procedural treatment now as routine for most patients?
So I will keep it simple, but that's right. What we do is that when they come from intracranial hemorrhage, we keep them with a single antiplatelet therapy, mostly clopidogrel. And when they come with a GI bleeding, we go with low molecular heparin. And I can't,
okay.
I mean, I know it's not we keep them for 3 months, 3 to 6 months. We do a CT, and depending on the result, we stop it completely.
Okay.
And I think I'm not wrong, but time will say. I mean, the thing is that in every study that is showing the bleeding thing, you realize that we thought that clopidogrel was had less bleeding effects in the gastrointestinal tract, and recent studies have shown that this is not true. So it's the same as giving aspirin. DIP, I think it doesn't give any extra. Instead, you are increasing your bleeding rate. So we have to be more creative. And I've been always pushing to take into account the bleeding source to have independent protocols regarding to the patients.
Yeah, interesting. I think you see there's many, I think there are as many post-procedural therapeutic antithrombotic recipes as there are operators, but that's an interesting field still to study. What I also truly believe, and I'm in line with you, double antiplatelet, there is no single study that shows that it's protective in one or another way for anything, not for device-related thrombosis, not for not for thromboembolic events, but you expose your patients to more bleeding. So that's for me also absolutely a no-go. But I think it's such a spectrum of patients you have, from high bleeders to high thromboembolic patients, that indeed it's a patient-tailored post-procedural treatment sometimes for me. I adapt it to the patient.
Yeah, I have to choose just one single therapy for all. I will go probably with a low dose of NOACs. That this is something that is being studied, and probably in the future we'll see that this is positive.
Okay.
I think we have time for a couple of questions.
I'm
afraid
we almost have to finish off. I think I looked to most of the questions. There's still one based on PROACT 17. Would you implant a patient that does not adhere to his drugs? That's maybe the final one.
We do it. We did it in the past, and we do it. I mean, when we see the INR is not proper and they have a irregular INR because they're not following the therapy, we go for closure.
Okay.
And
but
several studies where this was the criteria.
I feel like we can talk about this still for an hour or two, but then maybe we should once with a beer.
With a coffee. That's right.
Yeah. So I think that's all. Unfortunately, we have time for today. We hope that you really found this breakout session both informative and engaging. I would, of course, like to thank you, David, for joining me. I would also like to thank Boston Scientific for sponsoring this breakout today. And I can tell that this will be donated integrally to UNICEF, supporting women and children in the Ukraine crisis. And finally, I would like to remind you all to navigate your way back to the main program for more exciting content. Thanks for joining us, and goodbye.
Goodbye.